Hi, I'm Alan Moses, and I'm the inventor of the Moses and the new Moses Alpha. The purpose of this presentation is to introduce a new evidence-based scientific protocol to dental sleep practice. You will be amazed at how very simple and very inexpensive it is. It will change your practice. A successful oral sleep appliance should be positioned in the mouth to stent a stable position of optimal oral airway dilation. The new innovation is to establish a successful treatment position on the bite registration before laboratory fabrication of the permanent oral device. This is done by using a reliable, inexpensive home sleep tester to objectively validate the bite position before the sleep appliance is made. The benefits of this new scientific protocol are: successful treatment is assured at appliance delivery. Non-adjustable appliances is possible at greatly reduced cost, and it's validated by objective measurement. It's an ergonomic appliance, physiologic design, no screws, hinges, straps, tubes, rubber bands, or hinges. Okay, now let's get started. And so evidence-based sleep dentistry, how to fabricate a Moses trial device for validation before treatment. Here's the evidence-based protocol for delivering a Moses Alpha. 3 steps. 1, using FUTAR, make a trial bite registration device. 2, the Night Owl home sleep tester is used here to test or do tests to get the trial registration device validated. Has to be working. We know the results. It has to be good. Moses Alpha is only recorded after successful objective validation. The initial step is to establish a stable trial position of the maxilla relative to the mandible. Several objective measurement devices are available: the Moses Bite Sticks, the Moses Bite Shims, airway metrics, and pharyngometer are some. At least 3 millimeters of vertical is needed for a Moses. Now here's a demo. There is a demo of Dr. Moses. That's me using muscle testing, manual muscle testing, to find the initial bite. This video is available at the website www.themoses.com. This talk, however, is on how to make a trial bite for objective testing, validation by home sleep testing. This is a Moses Bite Stick. On the top, you see the actual stick. This is 3 millimeters of vertical and 3 millimeters of protrusive. And the teeth of the upper and lower fit in there at the position of 3 millimeters of vertical and 3 millimeters of protrusive. On the left there you see the complete bite stick. It consists of 9 breakaway jigs, captures the vertical of 3, 4, and 5 millimeters, depending on which one you select, captures a protrusive of edge to edge or 0, 1.5 millimeters, or 3 millimeters. These are the Moses Bite Shims. They're anterior bite wafers, 2 thicknesses, translucent is 1.5 millimeters thick. The blue are 2 millimeters thick. They are stackable by peg fit to a 0.5 millimeter of accuracy, and they're slidable if you go female to female when you put the sticks together. They're capable of registering vertical, lateral, and protrusive. Airway metrics jigs are interlocking sets for registering vertical and protrusive dimensions. The pharyngometer, a non-invasive wave tube reflected sound, measures cross-sectional area of the airway. Metric jigs are then used to capture the jaw position of maximal airway dilation. Okay, we're going to go over the bite stick method of making a trial device. The FUTAR bite regular set is highly recommended for registration and construction of the trial bite device. It's easy to work with in the mouth, is durable to sleep with in the mouth for several days if you need them. It may serve as a temporary at some future point, and it bonds to itself for easy repair or aesthetic smoothing. One of the 9 choices for vertical and protrusive is selected and broken off the wheel. The patient is instructed on placement of the teeth in the troughs of the bite stick and told, hold the stick in the mouth straight out parallel to the floor. That gets the upper over the lower, as you wish, according to the stick. Futar is extruded into the troughs of the upper and lower. Patient closes into the troughs in the perceived midline, until the futar sets. The anterior bite jig is then taken out, held in the hand by the patient, and then futar is going to be extruded in. The patient closes in an anterior bite jig in the pre-established position. Futar has a working time of about 30 seconds. Complete set, minute and a half, very fast. This is ample time. Okay, the futar is extruded over the occlusal surfaces of the lower posteriors, the lingual of all lowers, and the occlusals of maxillary posteriors, and lightly over the incisal of the anteriors, upper and lower. Okay, futar 90 seconds. The patient closes on the bite stick, and light finger massage of the cheek shapes the buccal flanges. The patient is instructed to spread the futar over the lingual areas, use the tongue and the inside to smooth it, and then close your lips. The stick is parallel, straight out, parallel to the floor. You can see that right there. Trial Moses bite is then removed from the mouth, and that's it. You're done with the bite stick. You've taken a temporary. You've made the temporary. Now we have to trim it. The range of the bite sticks, as we said, is 3, 4, or 5 millimeters of vertical, and from incisal edge, over incisal edge to 3 millimeters in protrusive dimension. Experience has shown that this range includes approximately 90% of all patients. Now we shift to the Moses bite shims, lower right picture. Moses bite shims are scaled for more sensitive vertical stacking in 0.5 millimeter increments and infinite sensitivity in lateral and protrusive dimensions. The shims can be used for 100% of all patients, depending on the sensitivity required and the comfort and your own desire as to what you hope to achieve. Bite shims is an anterior jig. The vertical has been established by a combination of stacked shims. Shims are smooth with the pegs out so that the interior surfaces contact smooth against smooth, which is also female against female, for capturing lateral and protrusive movement. For the final capture of the anterior maxillomandibular position, the upper and the lower shims are going to be luted together with futar. The futar handle is shaped for easy placement of the anterior template. So the vertical has been established. Put a little futar ribbon on the upper, futar ribbon on the lower. Patient closes on the shims. Now you take vertical. You record what you think with the patient as protrusive and lateral. And then when you get there, the upper and the lower shims are luted together. Then, if you want, you can put a little extra futar material. You can extrude it to create a handle for placement and easy removal in and out of the mouth. Note the handle for the patient to hold the jig. Practice placing the anterior jig in and out of the mouth. That's why the handle is nice. Hold the jig in the ready. The patient is told, hold the jig in the ready position while the futar is being extruded, and then put it back when you are told to do so. Okay, so the futar is extruded, again, the occlusals of the upper and lower, the lingual of the lower. The patient closes on the jig, and then it's put in the buccal cheeks bilaterally. Put the jig back in and bite on it, biting on the anterior jig segment. Extrude futar bilaterally on the buccal. Massage the cheeks. Note the handle that's there for facilitating easy removal. Okay, patient opens up and it's easy to remove the bite. That's what you see. This is the bite coming right out of the mouth, and then that's a view of the lower segment from the view of the bottom of it. And you can see easily the handle there. Now this is an important point. You need a brand new to extremely sharp scalpel blade to trim the futar. The device is trimmed. Removal of the shims creates an open anterior for replication of the Moses alpha. That's what you're doing here. You're replicating a Moses alpha in futar. Remember, very sharp scalpel blade. The handles are the handle is being removed from your futar handle, and then the shims are exposed and they're easy to remove. Then the lingual area is trimmed to clear as much space as possible for the tongue. That's the whole thing, clear enough tongue space so that it replicates the Moses. Incisal facial is trimmed to not be above the incisal plane of the mandibular anteriors. The area of the shims can be trimmed flatter. You could remove those little curvy lines. You could remove the pegs. You can cut it down lower. You can trim the lingual as much as you want. We want, again, as trim to thin as much as you can. You want the lingual to be thin for comfort and for the movement of the tongue, but you want it to be thick enough so it doesn't break off in use. And then in the upper flanges, you can round them off and thin them. Distal areas are removed from the shims if they're in the way. And then when you take the shims out, there's sometimes a little shelf, so you can smooth that out a little if you wish as well. There's the shim, smooth the edges where the shims were. The lingual plate can be thinned a little bit on many of these. You bevel the upper round and around the corners. Now here's two. This is using the bite sticks and not shims. The bite sticks have just come out of the mouth and they're ready to be trimmed. So first thing you do, remove the bite sticks, and they're easily removed with or maybe very slight trimming is involved. And then you start trimming them. Again, same kind of trimming. Excess futar is trimmed from the lingual, and then when you take the sticks out, there's sometimes a flange. There's a void where the flange was. You can cut that and flatten it out to make more room for the tongue if you have enough futar material. If not, you can leave it, or you can add a little futar and smooth it out. Make sure there's enough tongue space. Remember, the bite is supposed to replicate the Moses alpha. Make sure there is enough tongue space. Fill in or trim the void left by the flange if you want. Just leave it alone, as I said. Trim the buccal flanges on both sides so they're not puffing out the cheeks, just to make it a little more comfortable. Okay, so it's out of the mouth, and here it is. And if you look carefully, you'll see that this actually, in fact, replicates a Moses alpha, ready for home sleep testing in the patient's mouth. So that's the view from the underside. You can see the impression of the lower teeth in there. It's not exactly perfect, but all they got to do is sleep with this. Nothing's going to interfere. These little defects in a night are not going to interfere with any function, and the tongue is not going to be there. It's just a question of making this strong enough so that it doesn't break. There it is. Moses trial bite replicates the Moses alpha, ready for home sleep test in the patient's mouth. Plenty of tongue space. That's the key to this appliance. Night Owl Home Sleep Tester, that's the story. It's a very tiny little finger sensor. The finger sensor is taped with the sensor to the tip of the finger, and this tape that comes with is excellent. It's very low cost, fully disposable, easy instructions and application. Instructions and results are done via cell phone. The patient needs a cell phone. And a small finger sensor is taped to the finger. The results are sent to the clinician, and per sensor, you can do up to 10 studies per patient. So here's the evidence-based protocol. We're reviewing the first slide again. 1, using futar, make a trial bite registration. Number 2, the Night Owl Home Sleep Tester that is done on the trial device. And you can see the futar is a replica, and it's almost equivalent space and performance to the Moses alpha. The Moses alpha is only ordered after successful objective validation. So this is what you see. You do this, the patient goes home, turns on the app on that you put on their phone, and they get welcome so-and-so, and to continue. It tells them how to put the Band-Aid and the finger sensor on. On the right side, you see what the report looks like. It's a pretty complete report. It gives minimum SpO2. It gives this AAHI, and it gives pulse rate and maximum pulse rate. It even gives REM time and total sleep time. Very, very nice, complete study. And it's FDA approved, of course. Very reasonable at cost. Okay, bottom line, make and test as many trial bites as necessary. It just makes sense to do it before. Validate the sleep appliance before laboratory fabrication. Then you don't need any famous bells and whistles to make it look like an erector set. The material cost for a food chart trial bite plus a 9-hour test is approximately $17. The laboratory cost for Moses Alpha is $199. This is evidence-based dentistry at its best. The objective science, the cost and value of a quality service, and validation before delivery is immeasurable. And then when you're all ready, you send this case to Modern Dental Lab. They'll be happy to send you starter kit boxes. Just call up Modern, and they'll send you even some shims if you need, and maybe even a bite stick if you ask for it. Thank you.